I've been told to talk on one issue which I thought was common, but when I started with it, I noticed it wasn't really that common. That is professional relationship and interaction among doctors, and to pay attention to what is happening in Enugu State. I want to thank the organizers of this program for considering me wanting to stand here and talk on this topic. I want in a special way to thank the Nma chair of the state. I have no conflict of interest of any kind. I'm here as one of the doctors in the state. Before I could put down whatever I'm going to share with you this afternoon, I broached this idea with some prominent members. Some prominent members of our association. Dr. Ide was the former board chairman of this hospital, and at 80, he still attends every NMA meeting in Delta State, just like we have Professor Nairobi here. And a host of other people I have listed there. I owe them a lot of gratitude. So I have encapsulated that topic to the doctor-doctor relationship. I didn't know I would be talking to a heterogeneous audience. I thought doctors would really come here today and we talk to ourselves. But be that as it may, I welcome everybody that is here present. You can also extrapolate whatever you may have head here to your own. This is not synchronized. This is not synchronized. Okay. So, doctor-patient relationship is well established. It's been discussed, it's analyzed, and it's written, copiously. But the doctor-doctor relationship, by contrast, is neglected. When you hear that being mentioned, we're just talking on the ethical implication of our doctor-doctor relationship. For the purposes of this discussion this afternoon, I will, hinge my discussion on our Hippocratic oath, which incidentally we have recited it here. Some of us who are non-doctors may have realized that before you can practice medicine, that you have to go through oath taking. So that will be the basis of my discussion, especially where it says to hold my teachers in this act equal to my own parents, and also the considerations you have to give to your colleagues. The Hippocratic Act, oath embodied so many guidelines that will determine the behavioral interactions among doctors. In addition, it tells us how we are going to interact with our patients, how we are going to interact with the general public, and how we should look after ourselves. So, in the process of this discussion, we will concentrate mainly on how doctors will relate to their colleagues. Medical profession is a noble and respectable fraternity. I want to urge doctors to please mention this to every generation of doctors. Just like when you listen to lawyers, a lawyer will not finish 2 sentences without, reminding whoever that is around that this is a learned profession. Let us begin to talk about it so that nobody forgets that this is a noble and respectable profession. And those of us who are privileged to be members must do everything possible to maintain it the way it should be. We owe each other a lot. We owe each other something. So it is the duty of the senior to act as mentor, as a leader, as a guide, and to protect the interests of both the old and the young. While the juniors must respect, obey, and follow the leadership as directed. We must. Now, when we say that we are of noble profession, what does that mean? If you look up the dictionary meaning of noble, it tells you that it is something that says or has or shows fine personal qualities or high moral principles. It is excellent. It's of superior, quality. You can see that medicine is described with superlatives. So, it is something that if you happen to be a member, it is something to be, proud of. It's something that you must guide jealously. So, doctor-doctor relationship, I believe, should be next to patient relationship. Patient-doctor relationship in terms of importance, because of its bearing. It has a lot of bearing to the quality, the efficiency, and the availability of medical practice. Without coordinating this very well, you may have a lot of disharmony in the system, as I will illustrate as we move on. So, at what levels are we going to look at this? I have listed the levels: level of consultation, referral, group practice, mentorship, role modeling, and social and political side. We will leave the matrimonial part of it because doctors still marry doctors. That is not the level of our discussion we are going to look at. Now, let's look at the medical education has dual roles. The first role is to educate the doctor to acquire skill and knowledge. The second role is supporting the development of professional identity. I want to say that maybe that role of developing professional identity is lacking. That's why we have something like annual general meeting in the heart of Enugu today, with Enugu having more than 1,000 doctors, but this hall is practically empty. So, development of professional identity is something that doctors must cultivate, and it is doctors that will teach the doctors how that should happen. So, the university will do its own part by, impacting knowledge and skill, but professional identity is something that we need to look into and follow it through. I also want to let you know that as a doctor, being a professional is one of the 7 roles a doctor must play. 7 roles. And being a professional is a cardinal role. The other ones will include you are a clinician, yes. You are a scholar, yes. The commissioner spoke like a scholar. You are a manager. My brother here, Professor Nwadinigwe, is a manager of a big institution, of communicator, collaborator, and health advocate. But the most critical in the development and the character formation of the doctor is being a professional. And that's why the topic says the professional relationship amongst doctors. Let us look at how do we really develop this professional relationship. How does it come? Now, the professional role of a doctor is clearly outlined as follows. That as doctors, we have unique societal roles to play in caring for others. The role of caring for creation of mankind is vested in the hands of doctors. And this professional role is guided by the code of ethics and commitment to clinical excellence, embracing appropriate attitude and behavior. I underline attitude and behavior. If the attitude is wrong, if the behavior is repulsive, it is unlikely that the doctor will prosper. So these commitments form the basis of the social contract between doctors and the society. And when we have established this, the society gives us the professional lead in regulating what happens in the health industry. We don't really have to start struggling with anybody to say, oh, I am the leader of health. No, the society recognizes that. So we now look at professionalism. Professionalism, therefore, is a highly valued physician competence. And it manifests in the behavior of the physician, either in his private clinic, in the public hospital, or any other social gathering. When you see a doctor anywhere, you don't need to start asking, who is this person? The way the doctor talks, the way he behaves, the way he dresses will certainly stand that doctor out. So, when you see a colleague that dresses shabbily, it is our duty to also call the attention of that. If we see a colleague that is behaving inappropriately, it is also the duty of other professional colleagues to call that person to order. It is believed that these attributes are acquired through explicit education, socialization, and informal education, what is called hidden curriculum. If you pass through the medical school, there are consultants that impacted heavily in your behavior, your mode of the way you perceive clinical practice. I'm sure all of us, if you ask us individually, people will tell you who and who made what happened in your life. Let's also look at, I have in some informal way asked some of the deans of medical schools, how can we identify the professionalism competence in the curriculum of medical schools in Nigeria? Because I looked through some of them and I keep wondering, at what point is this professionalism, at what point is it being, where is it being taught, apart from some informal, teaching? So, we begin to ask questions. What factors are responsible for this gap in the medical school training of doctors, as when it comes to professionalism competence? It's been recognized that medical professionalism is a system issue in which the physician's behavior are profoundly influenced by contextual and environmental factors. By that I mean the curriculum of the medical school, the policies of the school, and very important, the role models amongst the teaching staff in that medical school. they determine to a large extent how the product of that institution, look at the medicine. There are recent studies that recognize that the greatest influence on the behavior of medical students and by extension resident doctors is the quality of the consultant and the clinicians that these students encounter and who often become their role model. So the effect of role model is very important and is regarded as a hidden curriculum that most people may not see in the books. So the content of the hidden curriculum are not taught in the classrooms. They are observable attributes which the students see and copy. They copy it whether it is good or it is bad. So that informs the importance of making sure that the university faculties are properly selected because they have tremendous influence on who becomes and the character of the next generation of doctors. So when the role modeling becomes defective, that is when you have what is called normalization of bad behavior. And with normalization of bad behavior, you now notice that over a generation of time, the professionalism and empathy begin to decrease. And the question is, can we formally articulate this professionalism in the curriculum and make sure that it is administered and evaluated? That is a big question. So when we look at the literature, you notice that so many people are of the opinion and argue that medical schools, for them to meet the societal expectations of future doctors, professionalism must be taught explicitly and adequately evaluated amongst the medical students. So what is happening around us? Already many countries around the world, especially the accrediting bodies, all right, have recognized the importance of developing professionalism competence, and therefore they have set standards that are required of medical school to identify where professionalism is addressed and how it is evaluated. If you look at North America and the US, even in Britain, they have those set standards. It is no longer something you have to assume that is there. Now, I believe that how the professionalism and competence is going to be taught is going to be a hybrid. It's going to be something that is formal in the curriculum as well as the role model, the faculties, the lecturers, the consultants that these candidates are passing through where, complement each other. So that at the end of the day, you have very refined professionals who can stand the test of time and stand the test of criticism. Now, the second issue that we need to look at is what is called professional identity formation. There are more recent authors have also recognized the importance of professional identity formation. To be a doctor, you don't learn to be a doctor. You are transformed to become a doctor. That is one major difference between other professions. You are transformed to be a doctor. And that is capped by the old taking. Now, professional identity formation, that is the foundation of physicianship. It is the process of internalizing a professional core values and belief. There may be some doctors that do not actually understand the values and the beliefs of the medical profession. Because if all of us do, I mean, whenever we have a meeting like this place will not be able to contain us. Attend the meetings of the lawyers. If this were to be the legal professionals, the whole of this compound will be filled. So that professional identity formation is very critical. That you don't wait for anybody to speak for you. You have to speak for yourself. Don't wait for anybody to validate you. You need to, bring it up. So, it is the process of becoming a good physician. You cannot be a good physician because you run to the clinic and come and go to the theater. No. There are a lot of policies that are impacting on your practice negatively, that if you're not around, some other person will speak for you. And when they speak for you, don't believe that all these people here, they like you. No, they don't. I need to tell you that it is only when you are there that you can say, oh, no, this cannot work. If you are not there, make sure you empower the ESCO, the leadership, to make sure that you are properly. So, that professional identity formation is critical. I attended the last graduation exercise of my alma mater. I went. At the beginning of the ceremony, when the registrar was already seated, there were, more than half of the candidates that were to be inducted were still outside. That was an aberration. By the time the white coat ceremony was to start, there were 4 or 5 candidates who didn't come with the white coat. So what did you come for? So these are things we need to gradually, re-emphasize. Let people know that you are a member of the noble profession. It is not something that, that you can wish away. As we move on, you will also see that whatever one person does rubs across all of us. Because once it happens, you say, oh, doctor did this. They don't classify, oh, it was this level of doctor or that level of doctor. What the press knows is that doctors did that. So, this professional identity formation is one area we need to talk, deal with it and make sure that it is, that it is something that nobody should overlook. Now, the next level of interaction we must look at is mentorship. Mentorship amongst doctors is very critical. I saw an article written by Richard Branson. He's the owner of Virgin Atlantis, for those of you in the business world. He said that the missing link between a promising business person and a successful one is often a good mentor. If you have a good mentor, no matter the circumstances, you are likely going to pull through. Now, I can extrapolate this to medicine. Many of us, I am a living witness, I have benefited immensely from, good mentorship. And you also will benefit as a mentor because it is the highest manifestation of personal maturity, security, and self-confidence. Mature people will always want to create people that are greater than themselves. They don't go about repressing or oppressing people. So it is important that for us to hand over, the best quality doctors for the next generation. The issue of mentorship must be, clearly and decisively dealt with. This is the particularly very important for those in academic medicine because they come in contact with these doctors at the budding stage. Whatever they manifest is likely what the next generation of doctors that will follow will also pick up. So the issue of role model, the mentorship, these are very formidable forces. And they need to be supported by a framework in the curriculum of most medical schools. Our faculty, physicians, and residents are very important role models for students. But you can only give what you have. You cannot give what you don't have. It is what you have that you can give. I also, now the next level of interaction amongst doctors will include issues of referral and consultation. If you look at our oath, it clearly states that I will not be ashamed to say I do not know. When you don't accept the fact that you have reached your limit, it is the patient that you are subjecting to, experimentation. So, you should be proud to call in the next colleague who you know who has the capacity to take this patient to the next level of safety. So it is desirable and indeed a requirement of our ethics that every professional in dealing with patients must recognize his own limitations in his skill and the facilities. You may have all the skill in the world, but the facilities may not have the requisite, armamentarium for you to really deliver. So you must be willing at all times to transfer this patient to the next colleague. Now, but you see, there are a lot of, disharmony in referrals. You see, in most cases, especially in the private hospitals, where the patients are delayed over a long period of time before the referrals, are done. By that time, you are no longer treating the initial disease, you are not beginning to treat the complications. The next issue there is, you also see colleagues making, derogatory remarks about colleagues. Somebody has referred a patient to you. You look through it and tell the patient, oh, this person actually messed up your leg. I mean, for what for? What are you trying to achieve? What do you want to gain from that? Right? So, the comments you make before the patient is very important, and it's been shown to be the most frequent cause of litigation, against doctors. So, as doctors, we must guide against that. We must, your colleague has sent you a referral. You look through it. It is mandatory that you should also, after looking through that patient, you do a reply to the doctor. If there are areas you think you should have done something differently, that is the opportunity you have to put it across. And not to begin to, make a derogatory statement before the patients. So we must begin to look at some of these issues. Sometimes you refer the patient with improper medical history in order to confuse or complicate the process of treating the other patient. That is wrong. You must transmit all available information, all right, the patient has, including the investigations the patient has, so that when he gets to the next person, he doesn't have to start all the process all over. One of the things I have also noticed in terms of referral is what is called fee splitting. It is a gross misconduct for any doctor to refer a patient because he hopes to get something out of it. I want to say this and say it clearly. I have also noticed that some of the medical tourism we notice in this country is also driven by, fee splitting. We must avoid that. We must, cease from doing that. As I said, it is also wrong for you to receive a patient without sending a feedback to the doctor that has referred this patient to you. Now, what we need to look at is also consultation. The same thing, similar things, happen with consultation. You have seen a patient, because of increasing technology, advances in so many subspecialties. Many of us are now, we know little about many more things that you need the collaboration of your colleagues. Within the same hospital setting, you have seen this patient and you refer the patient, you call your colleagues, please come look into this and advise. Because you may have had some issues with this person, that referral or that consultation is delayed. If it's not delayed, as a consultant, you have requested a colleague to see a patient. Instead of seeing the patient, he sends a registrar to go and review the patient the consultant has seen and requested for a help. And the registrar will go and, when you look at it, who is suffering? The patient is the one suffering. And somehow, the nurses tend to recognize it and tell the patient that this person that is seeing you is not actually the right person to see. And that is when problem begins to occur. So I want to urge colleagues, when issues of consultation come up, try as much as possible to respond to it. I'll give you a typical example. I noticed as a registrar at the teaching hospital, that was a gunshot injury that came to the hospital. This was around 11 p.m. in the night. And we prepared the patient. By 12:30 we were in theater. So opened the patient. It happened that this patient had gunshot injury to the retroperitoneal part of the geotomy. Those of you who are surgeons will notice that it is difficult to get access to this part of the gut. And the senior registrar who was operating with me called me and said, look, Dr. Nwadinigwe, don't be worried about the problem we are having here. We need to call the nurse in command. I said, by this hour? He said, yes. So by that time, there was no GSM. I had to go to the gate and call the consultant, who picked the, called immediately and told me that he will be with us in 10 minutes. 10 minutes he was with us. And that marked the difference between whether this patient is going to live or is going to die. Let us begin to talk about some of these things so that the younger ones will know. And some of those people I have mentioned are the generation of Professor Nohe. So, we need to let our colleagues know that the society has given us so much, to look after, that we must do that. I have been told that my time is getting shorter, but now we also need to look at group practice. We have listened to how doctors went from being at the topmost to struggling to feed, and the society is happy about that. It is only in medicine that somebody who can, who will buy a tuber of yam for 2,000 naira, and he will come to your clinic and tell you to give him the medicine of 10 naira. That is just the truth, right? We felt that, you don't really need to, he doesn't need to pay for the service. But I want to tell colleagues that so long as we continue to depend on government for practically everything, all right? I our lot will continue to depreciate. If you visit certain countries, you notice that what drives medical practice is group practice. When you see this consultant is in one room, the other one is at one 3-bedroom flat. No, pool resources together. Have a viable group practice. Group practice releases your time. If you want to seek for funds, you are able to get that. Right? So, in the process, when everybody is engaged, government will literally identify you as a champion in your district and then call you to come and head and you tell them your conditions. So we need to begin to look at that. Group practice is the way to go. If we don't do it now, we have to do it some other time. I'll tell you something. The former vice president of Rockefeller Foundation, you know Rockefeller Foundation, one of the richest families in America. He says the service given to a patient by group practice gains in quality by the criticism of other members of that group, whether the criticism is passive or fully expressed. When you are in such environment, a lot happens. And there is that conscious effort for you to continuously improve yourself. There are a lot more that we can talk about group practice, but let's quickly look at. I am not saying that you can't have a solo practitioner delivering quality service, especially if you know your limitations. If you know your limitations, you can comfortably do that. But I'm talking about a larger picture. Okay? Now, let us practice the profession with conscience and dignity. We need to do that and do it very well. We must respect our colleagues. Respect medical practitioners and dental surgeons should always endeavor to accord the senior members of our profession their due respect. Whether the junior interacts or interrelates with them, either in a professional or in a social gathering. You can't do otherwise. If you don't know how to do it, mix with the lawyers. All right? That you are called to bar a month before the other person. Automatically, the other person is your senior colleague. And you must so present it. Otherwise, you meet a sharp criticism. So let us emulate that. The older members of the profession should consider the junior ones as their brothers and strive to set a good example. More so when we realize that these younger ones are the ones that will look after us as we are aging. That is very important. This respect should cut across all our interactions, be it worldwide, with conferences. You notice that since we are here, any person that has passed through the medical school in Enugu campus, once you come here and see Professor Nohe, you won't be, it's impossible, the reflex that you must, give due respect to her. It is the norm that no professional fee. I am talking about how do we relate to our colleagues who needs our service. It is the norm that no professional fee is charged when a doctor looks after a colleague. I need to say something here. About 1 month ago, I was on my way to the airport and I got a call from one of our very senior colleagues who fell down in his bedroom and fractured they reduce and all. And I called one of our colleagues, also the younger one. He said, please, go to this place and check on this. He said, Chief, okay, I will, but how is it going to pay? I said, did you really hear what I said? That this is a colleague. Go and come back and he said, well, you see, it is part of bad professional identity. Because you heard that. I said, do you know this? He said, no, I didn't. He said, well, he taught people that taught me. Are you getting the point? So, the rule says, under no condition will you attend to a colleague and expect that you should be paid. Even if you have been paid. I give you another example. My son went to see an ENT surgeon. And during the process of the consultation and so on, he has paid for card. And after seeing the doctor, he saw them and said, are you a son of XYZ? Say yes. Say okay. By the time my son was leaving, he called the nurse and said, please refund this boy the consultation fee he paid. He came back and gave me back the money. And I called the doctor and said, thank you very much. And my son asked me, oh, why? I said, because I am a doctor. So, that is the way it should be. That is the way it should be. So, we must look after our own. We should see ourselves as members of special clan. You don't need anybody to tell you that. The next issue I want to emphasize is professional colleagues instigating litigation against colleagues. And this usually emanates from the side comments we make when we see patients that our colleagues have seen. The comments you make matters. Right? So, it is entirely a professional misconduct for a doctor in possession of any information about the patient to begin to instigate that patient to sue his professional colleague. It is unethical. It is dangerous. Because what comes round one day goes round. For those of us who are in the management position, myself, my brother, sometimes when we behave, our colleagues will not understand the basis for our behavior. Alright? The law says we must protect every aspect of the code of conduct of MTCM. And as such, if we see that being violated by any practitioner of medicine, we must report and deal with the matter decisively. So, sometimes that will push the administrators against the other doctors. And they say, oh, once you reach this level, you forget that you were once like us. No, it is the mandate given to the person as an administrator. I keep telling people, once what I'm doing now is a tenured job. Once I finish, I get back to the fold. So, it is important that we must be decent. We must exhibit high sense of decorum in our public and professional interactions. I have noted here that the current Nma Enugu, they are doing a lot to heal the maladies of the past. Those of you who watched what happened during the Nma election will stand here and tell you that this must never happen again in our votes. And I want all of us to resolve and say that that must never happen. Alright? I I was in a meeting in Abuja when somebody, a lawyer, forwarded that to me and said, is it true that these are your colleagues? It was an embarrassing question. So, decorum and decency is the watchword. I have been told that, 3 minutes, thank you very much. I will stop in the next 2 minutes. The last thing I want to tell you is that it is also unethical for you to poach the patients that is registered and is being attended by a colleague. You begin to entice that patient to come over so that you will do this. Or do you know that this person that is seeing you is not actually qualified to see you? That is totally wrong and unethical. Right? That happens a lot. It is wrong for you to do that at a professional level for your colleague. It is also wrong for you, if you are in a government hospital, to begin to entice the government patient to follow you to your private clinic. Please note that this is wrong. We must recognize that. Now, I was reviewing the Medscape of the most recent edition. There was a research that they were published, and he asked the question: should physicians have the higher standard of behavior than the general public? That's the question. Should doctors behave far better than the general public? And the overwhelming answer is yes. That we must behave far above average. He says choosing to become a doctor means that we have a contract with the society and the patient. That once we behave poorly, we project ourselves very lowly before the society and the patient. He also says, should doctors be able to act the way they want, whether you are in your professional office or at leisure? And the question is no. You should at all times know that people are looking at you as a doctor. And whatever you do touches every doctor around. That is very important that we realize that. So it is our duty to be our brother's keeper. And being our brother's keeper includes exposing professional misconduct. If your friend, a doctor, is a chronic alcoholic, is always drunk before he gets to work, call him to order. If he's not listening, take it to the next level. Right? If all those things listed in MDCM codes are being violated by any of us, please, it is our duty to do that must save the image of our profession. Finally, we owe a lot of duty to our association. I listened to Professor Obinna talk about our association. If we don't have a solid association, we have nothing to look at ours. If you look at all the gains of medical profession in the last 20-25 years, it is as a result of struggle. None of them came on a platter of gold. So, we must be a financial member of our association. We must avoid all situations. As at August 2nd this year, about 2 weeks ago, there are a number of doctors that are facing disciplinary panel. And the outcome of that panel has been published. I urge you to pick up a copy of it and see the judgment of the disciplinary panel. Let me quickly conclude. The conclusion I want to leave you here with is that there is absolute necessity for every doctor to see himself as a member of a special plan that must look out for one another. We must do that. The senior members must remember that the juniors will look after us. I have gone to the level of being the senior. But I am not yet at the level of emeritus professor, please. So, this is one of the major reasons we should develop the attitude of mutual responsibility, of respect, and not looking down on any member of our plan. Correcting every members with respect and dignity should be our watchword. Virtuous doctor can never, I want to tell the general public, those of you who are not doctors, that good doctors can never and will never intentionally hurt anybody. Please, so that when you see us in the public, accord us that little respect. We can never go wrong with righteous doctors. I therefore encourage you and demand from you doctors to check. So I therefore encourage all doctors here present that you should continue to push and demand for our colleagues to check their ethics and be very virtuous in their practice. Thank you so very much. A wonderful place. A wonderful place.